Okay, Jean-Paul, great to be with you. Where do you think the future of epilepsy treatment is?
Oh, that's a tough question to start. The future of epilepsy treatment, I think, at the moment is improving clinical care. I would hope that in the UK in particular, we're going to improve clinical care, more doctors, more people on the ground, specialist nurses, more motivation from GPs to help improve epilepsy care, and hopefully that will improve things for patients in the immediate future. There are other challenges ahead and hopefully other opportunities. I hope that drugs are going to improve. I would like to think that the number of drugs that we'll have is going to increase. Not that drugs are the answer in everyone, but I would like a bigger choice to be able to tailor-make individual drugs and tailor-make combinations to help target the individual epilepsy and individual patients. We're hearing lots of interesting things in the conference about gene therapy, about better approaches to surgery, better ways of working out exactly where the epileptic focus is so that we can try and act on that in specific rather than giving drugs that affect the whole brain. So there are lots of opportunities and hopefully the future will be even more diverse than we think it is just now.
Okay, do you think it's important for a patient to understand their condition and be involved in the treatment process?
Really important that we get patients engaged in their condition. We really need patients to know A, what their diagnosis means to them in terms of their home life and their working life. Vital, absolutely vital to realise the place of medication and the place of their own lifestyle modifications to try and reduce the impact of seizures and epilepsy on their life. It's only when we get patients involved as being partners in their illness. It's only then. They don't want people lecturing to them from on high. They want to be able to take active decisions in their own treatment so that they can help reduce the burden of epilepsy, bring them back to as normal life as possible with least intrusion from epilepsy and least intrusion from side effects from drugs.
And what will you be presenting at the Congress, or have you already presented?
We've had several interventions in the Congress. We've got a forum near the end of the Congress which is looking at cardiology and neurology, looking at ways in which the heart sometimes can change and affect presentations of epilepsy and cause things that can sometimes look like epilepsy. At the same time, it's also looking at the ways that epilepsy can sometimes affect cardiac function as well. And this interrelationship between heart and brain, I think is quite interesting and may well help clarify exactly why some patients have a more serious type of seizure and sometimes serious side effects from seizures. We've also been looking at, I've forgotten what else we're looking at. What else have I done? Oh yes. The other thing we'll be looking at is a teaching course, and there's a day-long teaching course near the end. It's quite a new innovation, looking at different medical causes of epilepsy. My particular role in this is to look at drugs and alcohol and lifestyle changes and their effect on seizures and their effect on epilepsy.
Are more people looking into that area at the moment?
I think in the UK, the effect of alcohol and epilepsy and the alcohol and health in general is becoming a huge issue. And many doctors, not just neurologists, but we're looking at doctors specialising in liver diseases and blood diseases and all sorts of disorders, are noticing that alcohol is playing a bigger and bigger part in producing problems for society at large. Many drugs are also, illicit drugs are becoming more readily available and becoming almost in some senses socially acceptable. And there's a lot of mythology out there about some illicit drugs that are supposedly helpful for epilepsy. I think this mythology has really got to be cracked. I think we're having seen more and more people, both acutely and long term, who are developing problems as a result of exposure to drugs.
Thank you for that. And which sessions are you excited about going to at the Congress?
Gene therapy is really going to be an exciting field. We're looking already at different ways in which we can try and change the genetic makeup of cells that have been damaged as a result of seizure activity, as a result of other disease processes as well. And I think to be able to help seizure-related areas to help themselves get these damaged areas to produce different chemicals and different compounds and affect their own protection, if you like, in the long term. I think that's really going to be fascinating.
The other questions are, how do you think epilepsy services in England compare to other countries?
I think epilepsy services across the UK have improved over the last 15-20 years. We're in a much better place for treatment and management of epilepsy than we were at the turn of the century. I think epilepsy services across the UK may still be quite patchy. I'm a bit concerned when I look at the effect of commissioning in England. That's not reached Scotland yet. I don't think it's hit Wales or Northern Ireland. In Scotland, I don't think we're going to have the problems with commissioning. There are still ways forward. In a sense, the health service just now is absolutely obsessed with waiting times and other directives. That's been good up to a point, but that focuses on quantity. That looks at the number of patients that we process through. It's not yet looking at quality. It's not yet looking at how well we can treat people, how often we can see them, how much we can control their seizures. The impact on GPs of their recent targets and their recent cost rewards, we're still to see that yet. We've seen the work change. I'm not sure that we've seen GP care of epilepsy improve as a result of these QOF measures.
And how effective do you think commissioning for epilepsy services is in the UK?
Again, the commissioning is so far a local problem in as much as it affects England rather than the UK in general. I've not had any personal experience of any deterioration in services, but I have to say, when I talk to my colleagues in England, I hear more problems than I hear praise.
Why should the trusts or boards continue to review their services?
We know that epilepsy is common. We know that epilepsy, when it's poorly treated or undertreated or untreated, causes a lot of problems. If you can face these problems, if you can reduce accident emergency visits, if you can reduce hospital admissions, this is a cost saving in the long term. Now, trying to get the evidence together so that we can convince people that it makes financial sense to try and nip these problems in the bud, that prevention's much cheaper than cure. If we can convince them of that, then we can really persuade them, I hope, that providing better primary care services, providing epilepsy nurses that can give patients immediate access to help as and when they need it, provide first seizure services that can help improve diagnosis and hopefully allow better, more efficient investigation and more efficient use of treatments.
Do you think there are any advantages of providing services in the community as opposed to the hospital?
When we look at the UK, traditionally we've tended to focus on hospital care for diseases like epilepsy. I can see the advantages of primary care. Patients want services to be local. That's only true up to a point. There comes a time where we need specialist services, and when specialist services are needed for severe epilepsy or detailed workup of epilepsy, then we've got to always remember we've got to keep a real investment in our secondary care and tertiary care for epilepsy.
Can you tell us why you think a quick and accurate diagnosis of epilepsy is important?
We know historically, when we look at bodies of patients in the community and attending hospital for treatment of epilepsy, if the diagnosis hasn't been made by a specialist, there's two main things that happen. Number one, too many people slip through the net and don't have a diagnosis of epilepsy, yet are faced with long-term treatment and care for a diagnosis which is not accurate. 20% of patients can be left with that. When you get specialists involved, not only do you hopefully reduce that level of misdiagnosis, but you allow treatment to be targeted. It avoids using old drugs, avoids using too many drugs. It allows us to focus in on the correct classification, which means we can get the right drug used for the right patients, hopefully at the least dose with the least side effects.
Jean-Paul Leach, thank you so much.
Thanks very much.